Good evening, one and all present here. I am Monalisa from Clearnet, the designated session assistant for the seamless experience, and Clearnet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. Clearnet is very proud to be a part as a digital partner for this event organized by Society of Onco-Anesthesia and Perioperative Care. And the topic of today's session is new advances in perioperative pain management in thoracic and abdominal surgeries. So, thank you for your patient hearing. Let's begin today's session, for which I would like to invite Dr. Shohan to take over. Over to you, sir.
Dr. Sohan is a little okay.
Hello.
Right.
Yeah. So for today's talk, actually, I invite our founder, secretary, and our ex-professor of anesthesia and currently the professor of palliative medicine, and Dr. Raghu Thota. So, Dr. Thota, please, please start the session, and it's all yours.
Good evening, everyone. Am I audible?
Yes, we can hear you.
All right. Yeah, thank you very much for inviting me to chair this session on new advances in perioperative pain management in thoracic and abdominal surgeries. It's a very important topic, especially in thoracic and abdominal surgeries, because now we are moving away from the neuroaxial blockade. Though neuroaxial blockade is a gold standard, but still there are various advances and techniques in regional anesthesia which have emerged over a period of this last decade, especially in the form of fascial plane blocks. And that's why this topic becomes of utmost importance, especially for those who are practicing onco anesthesia. So here we have our very own Dr. Sheetal Gaikwad. She's an associate professor at Tata Memorial Hospital, who is trained in regional anesthesia. She has done a fellowship from Germany, and she has a special interest in acute cancer pain management as well as chronic cancer pain management, as well as a difficult airway. Why I'm telling she's well trained is that because I have worked with her and she really knew the fascial planes very well, and she is actually a master of this specific regional techniques. And I hope that she will enlighten everyone with her
Hello.
of onco anesthesia. Over to you, Dr. Sheet.
Yeah, thank you. Thank you very much, sir. I hope I'm audible.
Yes, we can hear you.
Yeah, okay. So I'll just start with my slideshow. So basically we are well versed with the topic. It's about new advances in perioperative pain management in thoracic and abdominal surgeries. So like human evolution, the regional blocks also has evolved over a period of time. We started initially with spinal anesthesia. Then came the era of epidural, where we moved away from the spinal cord. We started adding opioids because it gave good quality analgesia. Then came an era of peripheral nerve blocks. Initially, landmark guided, PNL guided, and then the ultrasound was used rampantly. And now we are going away from the nerve itself with the advent of fascial plane blocks. So the success of any blind procedure is questionable till we see the results. Generally, the neuroaxial blocks are given blind. The ultrasound is most commonly used for peripheral nerve blocks and for the fascial plane blocks, wherein we can see the target and give the local anesthetic agent. So the chances of success are much higher in these blocks. Now we start with what are the problems with these fascial plane blocks. The first problem is there are too many nomenclatures. TAP, PEG, Serratus, QLB, MTP, RLB, RISS. Oh, what is this? Which should I use? So this is a big problem. There are too many nomenclatures. before going to the next problem, first thing what we should know is something about fascia. So what do we know about fascia? Now, what is fascia? Fascia is a collagenous, loose, fibrous connective tissue that encloses muscles and separate them from other structures. There are two types of fascia. One is the superficial fascia here, and the other is a deep fascia. The superficial fascia basically supports the subcutaneous tissue and it helps in the skin integrity. Deep fascia is the one which we are interested in, and most of our blocks are done here. So basically, it ensheaths the muscle, it blends with other structures, example, muscles, ligaments, and joints as well. There are two subtypes of deep fascia, and those are epimysium and aponeurosis. Now, let's see about epimysium and aponeurosis. So, epimysium is thinner, right? This is the one. It's thinner. That's the reason the local anesthetic agent easily diffuses through it. And it is adherent to the muscle. And that's the reason it is difficult to inject with precision. The best example is a tap and a flex block. So tap, most of us have given the tap block. In that, if you see, we always feel that we should go little in. When we go little in, we feel we should come little out. But we don't know what is right. So this precision is lost. But the best thing is it is thinner. The fascia is thinner there. So even if you are a millimeter inside or outside, there is an easy diffusion of a local anesthetic agent. Now with aponeurosis, the best thing is it is thicker, right? And it is easily separable. So because it is thicker, you can see in the ultrasound, the aponeurosis very, very well. And you can get a tactile feel of the needle when you enter the aponeurosis. That's the reason it is easier to inject it with precision. However, the problem is there is less diffusion. So the best example is a rectus sheath block where you can see a beautiful goosen egg appearance or injection of a local anesthetic within the plane. And this LA remains within that aponeurotic plane. Now let's update ourselves more with about the fascia. So apart from this, now we know that fascial plane communicates. For example, a thoracolumbar fascia. Thoracolumbar fascia communicates with the endothoracic fascia as well as with the gluteal fascia. Now the problem is, because of this communication, our control over the spread of local anesthetic agent is lost. Fascia is continuous. It is uninterrupted, right? So again, the spread is there, which is uncontrollable. Fascia is perforated and it is not impermeable. So there are macroscopic perforations in the fascia. Apart from that, the blood vessels and the nerves which travel through the fascia makes a room for carrying the local anesthetic agent as well. Fascia permits gliding. A fasciocyte secretes a hyaluronan which helps in facial gliding. pH of the body, the temperature of the body are something which affects the secretion of hyaluronan. Somatic and sympathetic nerves travel in and through the fascia. Fascia is also innervated by somatic and sympathetic nerves, which get blocked by the injection of the local anesthetic drug. Now we come with the mechanism. So basically, again, the problem is we don't directly put the local anesthetic at the nerve, which is beneficial, but at the same time, we are giving a proxy block. So the mechanism could be the diffusion of the local anesthetic agent, the bulk flow of the local anesthetic agent. The sympathetic and the somatic nerves are directly affected by LA, and nerves to fascia and the muscle also get affected. There is a systemic absorption of the local anesthetic drug, which also gives analgesia. So as more and more evidence come up, we'll get a clear picture, but as of now, we know this is the mechanism of action of facial plane blocks. Now, by and large, till now, what we have learned is the somatic, the visceral, and the motor part plays a very important role in a total pain of a patient. But at the same time, now with the facial plane blocks, we have come to know that the muscles, the fascia, the ligaments, and the bone, they are all very, very important structures. There are a lot of nociceptors there. With the inflammation, there is upregulation of these nociceptors, and a direct injection at the fascia giving analgesia at all these regions has a great impact on the outcome of the patient, giving a good analgesia, and it decreases the opioid requirement. So now we'll see what are the controversies with the facial plane blocks. First is facial interconnectivity. As discussed, TLF is in continuous with endothoracic fascia. So we lose a degree of control, especially for the paraspinal blocks. Predictability is a problem. So we are not sure a facial plane block given in a supine position will spread more than given in the lateral position or than given in the prone position. We don't know what will be the effect of the ventilation, what will be the effect of the spontaneous respiratory movements of the patient, what will be the effect of the muscle contraction at that particular point. We don't know if it is going to affect our outcome. There are a lot of technical factors. For example, the kind of needle which we use, the point of injection where we are going to do it, right? The ultrasound image which we are going to see, right? And the pressure that we are going to give to inject the local anesthetic drug. We don't know if these factors are ultimately going to affect the outcome of our block. A patient with a history of myofascial pain indicates that probably there is a facial plane dysfunction. Whether to give a block in these patients, we don't know. If we give a block, is it going to give a good analgesia is what we really don't know. Line of fusion. So in our body, we have got a physiological line of fusion that is called as linea alba, wherein the two fascia fuses and forms the linea alba. Because of the linea alba, the local anesthetic drug put in a one compartment doesn't cross over and goes to the other one, right? That's the reason we have to give a bilateral rectus sheath block for a midline incision. But the problem is this line of fusion can be pathological also, maybe because of scar, due to trauma, due to surgery, due to aging, due to diabetes, due to multiple factors. So in that case, we just can't predict the endpoint of our block. Is the fasciotome equal to dermatome? We are not sure. Fasciotome is moreover related to a myotome, but is it related to a dermatome? We don't know. We're still working on a final mechanism of action. We don't know what is the ideal volume of the local anesthetic drug needed for every facial plane block, the success of a block. So any patient receiving a facial plane block may or may not give a discernible cutaneous analgesia, but the patient might get benefit with in terms of pain relief and in terms of opioid requirement. Now, should we call this block as a failed block? We don't know. There is no simple answer for this question. Side effects. So far, there are no any side effects reported for the facial plane blocks. But are there no any side effects of the facial plane block is what we mean to say? No, it can't be, right? Anything going in will have certain side effects. So theoretically, we have last local anesthesia systemic toxicity and the myotoxicity, which can occur in this facial plane blocks because of the large volume and the large concentration that is given. And the other smaller complications could be catheter related, like catheter kinking, the drug coming out of the catheter is accidentally pulled out. And so all these side effects are there with the facial plane blocks. Now, we will just try to do a thoracic nomenclature of this fascial plane blocks. So depending upon the point of the injection of a local anesthetic agent, the blocks are divided into posterolateral, anterolateral, and anteromedial. Posterolateral blocks are the paraspinal blocks. Those are the erector spinae, midpoint of transverse process to pleura, retrolaminar, rhomboid intercostal blocks. Anterolateral are all the serratus blocks, and anteromedial are the parasternal and TTP, that is transverse thoracic plane blocks. Little confusion, will make it very, very easy, don't worry. So now first, let's see the anatomy of the intercostal nerve. So a spinal nerve emerges out of the spinal cord. It divides into a dorsal ramus and the ventral ramus. The ventral ramus is carried forward as an intercostal nerve in between the intercostal muscles. It gives multiple branches there. The most important branch is the lateral cutaneous branch, which ascends through the intercostal muscles and then to the serratus anterior or the external oblique, depending on what is the location of that intercostal nerve. The lateral cutaneous also gives number of branches to supply or to innervate surrounding areas, the surrounding structures like ribs, muscles, and ligaments in certain cases. The intercostal nerve is carried forward and then it ends as an anterior cutaneous branch, which ascends at the parasternal area. So this is in short about the root of the nerve. Now let's see where and how do we inject the LA and how does it exactly happens. So first we start with paravertebral block. So in the paravertebral space, we have a dorsal and the ventral ramus. A paravertebral block is given in this space wherein we get a good analgesia and also gets a autonomic. We can get an autonomic dysfunction like hemodynamic effects and all. Now we will see a MTP. So midpoint of transverse process and pleura is a block where we inject a local anesthetic drug between the pleura here and the transverse process. This is an ultrasound image of the MTP. So if you see here, the paravertebral space is very close by to the MTP catheter. And there is only small costotransverse ligament, which is there in between the space and the MTP catheter. Of course, it is with perforations, right? So the drug placed here will definitely travel to the paravertebral space and give a good analgesia. So this block becomes a little bit of deeper block than that of the other or rest paraspinal blocks. The literature is still coming up with the MTP and we are awaiting for more and more as of now. So erector spinae is a well-known block. In the erector spinae block, the local anesthetic drug is injected over the transverse process where you lift up the erector spinae muscle, right? If you trace the plane inside more medially, you can see a retrolaminar block wherein the local anesthetic agent is injected just above the lamina. However, there is a hindrance of lamina. That's the reason retrolaminar block has not shown to be that effective, but again, the evidence is not much. Now, let us trace the same erector spinae plane. So if you trace it laterally, you can see a rhomboid intercostal and subserratus plane block, which is almost in the same plane at the end of the at the end of the erector spinae muscle. If you trace the same plane laterally, we have a serratus anterior block. It can be a superficial or it can be a deep block. Superficial is nothing but an injection of a local anesthetic agent above the serratus anterior muscle, and the one deeper is a deep block. And the PEX block. So SIFB, serratus intercostal fascial block is also a deep block, which is where the local anesthetic is placed deeper to the serratus muscle. So all these blocks block the lateral cutaneous branch of the intercostal nerve, and it gives a good coverage at the anterolateral part of the chest wall, right? And the medial blocks for the anterior medial part of the chest wall, we have pectointercostal fascial plane blocks and the transversus thoracic fascial plane block, which we'll see further. So that gives a good anteromedial coverage of the chest wall. Now, these are various thoracic incisions. So the most common is posterior lateral thoracotomy. If I have to choose something, I'll choose a ESP for this. The median sternotomy plus the anterior lateral thoracotomy. So median sternotomy will need a bilateral parasternal blocks. And for the anterior lateral thoracotomy, we can use a serratus or a ESP. Robotic and VATS surgeries, we can see that patient do have a utility incision. Sometimes this utility incision is also extended, which is very, very painful. And most of this patient don't have an epidural. Serratus anterior or erectus spinae block is the best for these kind of, or this set of patients. Now let's start with the etugel block. So erectus spinae block, as discussed here, we inject a local anesthetic drug over the transverse process and we lift up the erectus spinae muscles. The coverage that the ESP gives, the best coverage is at the posterolateral part. So any fascial plane block gives its best coverage at the point of injection and the area around it. So the loss of cutaneous sensations are more prominently seen here. This part, maybe the cutaneous sensations don't go, but the analgesia is still there. Let's look up with the literature. So there are more than 500 publications of ESP on ESP, including 36 systemic reviews, 4 meta-analysis, and 16 RCTs, and many more case reports. Systematic reviews and meta-analysis strongly support a postoperative analgesic benefit of ESP up to 24 hours when compared with no block in thoracic, breast, and abdominal surgeries. Among the RCT studies, the cohort includes the thoracic, breast, and the cardiac surgery. Now, based on these publications and this evidence, the indications of ESP are in thoracic surgeries, ESP gives equal benefit that of the paravertebral, which is little lesser. So serratus has got a little lesser effect than the ESP. For breast surgery, pectoral blocks hold the upper hand. For the cardiac, TEA was equal to ESP, probably because the evidence is limited. And again, maybe the TEA was not as appropriately used because of the hemodynamic changes. We don't know. The evidence is still coming up. So based on this, the level of evidence for thoracic wall is level 1A for the ESP. For breast is again level 1A, and upper or lower abdominal surgeries is also a level 1A evidence for an ESP. For VAT surgery, as per the prospect guidelines, a regional analgesic techniques such as paravertebral block and the erectus spinae plane block are recommended. Serratus anterior plane block can be used as a second choice. Opioids should be used as rescue analgesics postoperatively. So they should be used only as a rescue analgesic and not as a primary analgesic technique. Thoracic epidural analgesia is not recommended for postoperative analgesia for VAT surgery after weighing the benefit and the risk. Now, our tips and tricks of success of the ESP, we feel that the sitting position is better than that of a lateral position, because in sitting position it was easier simultaneous visualization of a needle and a target, which was possible. For any fascial plane block, we have to give an adequate time for spread and action, because basically the mechanism is diffusion and a bulk flow, which takes time. Air is an enemy of ultrasound, so always use a needle primed with saline. Serratus anterior plane block. So for serratus anterior plane block, we lay the local anesthetic drug between the latissimus dorsi and the serratus anterior muscle at the level of mid-axillary line on rib 5 and rib 4. If we lay deeper to it, it's a deep block, deep serratus plane block. The coverage is moreover the anterolateral part of the chest wall. And it blocks the lateral cutaneous nerve, is what we have already discussed. Now let's see the evidences for SAPB. So based on the meta-analysis, we have seen that the serratus anterior plane block has reduced the pain scores. The requirement of opioids in 24 hours was low, and the chances of PONV were reduced. Longer time to first analgesia request. Based on the systemic reviews of 9 RCTs, cohort studies, case studies, and case report, we found that a single shot injection of serratus or a PEX blocks were noted to be approximately 6 to 12 hours longer than the intercostal blocks and is shorter than the single shot paravertebral block. Now, this could be because when the intercostal block is given by the surgeon, there is a rent in the parietal pleura. So the local anesthetic agent might not stay, right? We can also get a false impression, even if you give it intramuscularly and we see a bulge, that it is in the intercostal space, wherein it might not be in the intercostal space. So because of all these reasons, fascial plane block play an important role in the VAT surgery, even a single shot, because the duration of action of analgesia is prolonged. Meta-analysis of 8 RCTs says that fascial plane blocks do give a good analgesia. This analgesic superiority did not translate into the faster chest tube removal or a shorter length of stay. Now, there are very few RCTs of TEA versus serratus or a PVB versus serratus. But based on that, whatever literature we have, it is found that there is no difference in the morphine consumption in both the groups, while SAP was associated with less hypotension, and there was no significant difference in post-block inspiratory volumes or pain scores. This is which is very important. Okay, so now we go for the indications of SAPB. Breast has got a level 1A in indication of a serratus. For thoracic surgeries, including VATS, it has also got a level 1A by providing a reliable coverage from the anterolateral chest wall axilla to the posterolateral chest wall region. Its use has also been reported as a proof of concept for managing pain secondary to blunt chest trauma, multiple rib fractures, and inferior scapular fractures. Post-mastectomy and post-thoracotomy pain syndrome, level 1B evidence. So this is how serratus anterior plane blocks are useful in thoracic surgeries. Now let's run through baby blocks. So the parasternal blocks are mainly called as baby blocks. There are two types of block. One is pectointercostal fascial plane block and the transverse thoracic plane block. So in case of pectointercostal fascial plane block, we inject a local anesthetic drug below the pectoralis major, right? And above the rib. For the TTP, transversus thoracic block, we inject a drug between the internal intercostal with transversus thoracic, between the internal intercostal and transversus thoracic muscle. The problem with the deeper block is pleura is very close to it. And many a times internal intercostal muscles and transversus thoracic are so intermingled that it becomes very difficult to separate them. Plus the pleura is also very close. So the best would be to give a superficial block. This block will block the anterior cutaneous nerve and it will give a anterior relief in the anterior medial chest wall. Let's see the evidence. Now, in case of median sternotomy pain after cardiac surgery, to block or not a systematic review and meta-analysis was done, and this meta-analysis suggested that parasternal nerve blocks significantly reduce the postoperative pain and opioid use. Their use in thoracic surgery needs to be more studied. There are no meta-analysis as far as we know. So we are just waiting for the more robust data to come up on thoracic surgeries. Now let's go on to the abdominal wall nomenclature. Now there is no any abdominal wall nomenclature that is there in the literature. I've tried to just divide it again depending on the needle position for the simplicity so that we can remember these blocks. So posterior lateral, like that of the thoracic surgery, like that of the thoracic facial plane blocks. Posterior lateral, we have paraspinal blocks, the quadratus lumborum 3 and quadratus lumborum 2, the posterior tap block. We'll deal with it one by one. The anterolaterals are the lateral tap, external oblique intercostal in upper abdomen, QL1, and the subcostal tap. And the anteromedial is strictly actually a rectus sheath block. Nomenclature of tap block. So the tap block is further divided into a subcostal tap, oblique subcostal, lateral tap, posterior tap, and a four-quadrant tap block also. We'll first see the anatomy of tap block. So the muscles in the anterior abdominal wall from superficial to a deep part are external oblique, right? Then internal oblique, and then is the transversus abdominis muscle. These three muscles form a aponeurosis and forms an anterior and posterior rectus sheath anteromedially, wherein the rectus muscle lies between this rectus sheath. These three muscles also form a aponeurosis at the posterior lateral part, right? Now let's see about the nerves. Now, as we've already discussed about the intercostal nerves in the thoracic part, the upper abdomen is also supplied by the intercostal nerves from T6 to T11, right? So it has also got a similar course. Now, just that we have to remember one thing, that the lateral cutaneous branch is taken off at the level of mid-axillary line, right, which we need to block. And there is a variation in the takeoff of this lateral cutaneous nerve. So that's the reason it's better to block as posterior as lateral as possible to get a good analgesia. And the anterior cutaneous nerve, as we have seen in thoracic or a chest wall blocks also, in a similar manner, this anterior cutaneous branch pierces the rectus abdominis muscle and gives an analgesia at the anteromedial part of the abdomen when it is blocked. Now we'll go with the subcostal tap. So a subcostal tap, as the name suggests, it is below the costal margin. We have placed the probe obliquely, and the point of interest is in between the posterior rectus sheath and the transversus abdominis muscle and the aponeurosis. So basically in the linea semilunaris, depending on the spread of the local anesthetic drug, we get a good coverage. If you give a good volume and the spread goes more laterally, we get a good lateral coverage. Otherwise, it stays only, if it stays only in the medial part, we will get just a analgesia at the anteromedial part of the abdomen. Lateral tap. So in lateral tap, we inject a local anesthetic drug at the level of mid-axillary portion, wherein we inject a drug between the internal oblique and transversus abdominis muscle, right? And this is just to remind all of us that the takeoff of the lateral cutaneous is at the level of the mid-axillary. in most of the patient, but sometimes there are variation. So try to give as lateral as possible. Posterior tap. So basically here the injection by a landmark technique is at the triangle of Petit, but with the use of ultrasound, how do we understand where we are injecting is we trace these three muscles laterally, as lateral as possible, and then we can see a aponeurosis of internal oblique and the transversus abdominis muscle, wherein we can lay the local anesthetic drug, which is nothing but the posterior tap. There's a very fine line between a posterior tap and a quadratus lumborum 1 block. So as and on we go ahead, we will understand it. Now let's see the evidence. There are numerous meta-analyses that have shown that tap blocks reduce opioid requirements in the postoperative period after the abdominal surgeries, total abdominal hysterectomies, colorectal surgeries, and laparoscopic surgeries. The comprehensive review on tab block done by Tran et al. Does provide the authors expert clinical recommendations for tab block based on the reviews of 245 articles. Based on this, the area of coverage, the oblique subcostal block has got a better coverage than that of the posterior, which has in turn got a better coverage than that of the lateral tab block. The tab block has been used to provide analgesia for various abdominal surgeries, including gastrointestinal with a level 1A evidence, and gynecology, again a level 1A evidence. Colorectal surgeries, level 1A in the absence of thoracic epidural, as well as the lap cholecystectomies. Prospect guidelines for open liver sections. They've said that use either thoracic epidural or a oblique subcostal tab block. So it is inculcated in the guidelines that oblique subcostal tab block gives equally good analgesia that of as that of the TEA with minimal side effects. Basically, for the liver surgeries, the coagulopathy, the blood loss, all this plays important role, and hence oblique subcostal tab block is could be equally used like that of the TEA. So based on this narrative review for tab block, optimal dosing, there is no difference in the concentration, low versus high. So the low concentration of 0.125 versus high concentration of 0.5 gave a similar kind of analgesic effect. However, the volume required was more than 15 milliliters per side. Dosing should be based on a lean body weight to avoid last. Bolus versus continuous. So there are few randomized trials on bolus versus a continuous tab block. So the advantage of the bolus block is that one thing, it is better economical. Bolus block is more economical than that of an infusion pump or a Baxter. Second is, when the bolus was given for 3 days, there was no any regression of the block. However, in continuous, it was found that there was a certain amount of regression that was seen. Also, the pain scores or the duration of analgesia was more better with bolus than that of the continuous blocks. Rapid first phase absorption kinetics, mean time to maximum serum concentration is 10 to 35 minutes. So this is something which we need to know, that a maximum serum concentration can occur after 35 minutes too. So we have to be safe with our dosing, because patient might get clinical features or clinical symptoms of local anesthesia systemic toxicity even after 35 minutes. If in epinephrine decrease causes 35% decrease in the plasma concentration. Optimal local anesthetic drug. So ropivacaine versus bupivacaine, there is no difference. Bupivacaine versus liposomal bupivacaine, there is no any evidence so far. Bolus versus continuous catheter, the evidence is there, but it is so we need more to come to some conclusions. 4 catheters versus liposomal, we are still waiting for the evidence. Let's go to the rectus sheath block, a simple block, a poneurotic block, wherein the local anesthetic drug is laid between the rectus abdominis muscle and a posterior rectus sheath. Fascia transversalis lies beneath it, right? And it blocks the anterior cutaneous nerves of T7 to T12. Compared to the tab block, number of available RCTs and meta-analysis are limited. RSBs are usually performed under ultrasound guidance and are primarily used to help with surgeries, having a midline incision for the anterior abdominal wall, a level 2A evidence. It has also been used with open gastrectomy with level 1B and splenectomy with level 1B evidence, and for laparoscopic procedures, including laparoscopic gynecological surgeries, level 1B, and also in the pediatric appendectomy with a level 1B evidence. TAP versus rectus sheath block, again a limited evidence. Rectus sheath block is strictly confined to midline incision, while TAP block also covers the lateral incision. TAP block may provide a longer postoperative analgesia. So this is a kind of coverage that we have with these different kinds of block. Rectus sheath block covers the anteromedial aspect of the abdominal wall, the midline incisions like this. Subcostal tap block, depending on how is the flow of the local anesthetic agent, the kind of analgesia we get is something like this and like this. The lateral tap block is from T10 to L1, so covering this area, the lower abdominal area. Let's go to the quadratus lumborum anatomy. Okay. So we know now little bit about a thoracolumbar fascia. So this thoracolumbar fascia is a thick fascia. It is divided into middle, anterior, and posterior part. The quadratus lumborum muscle is sheathed with middle and anterior TLF. So here there is a middle TLF and here there is a anterior TLF, right? So based on this location of the local anesthetic drug around this quadratus lumborum muscle, it is classified as QL1, 2, and 3. QL1 is a lateral QL wherein the local anesthetic drug is laid below the aponeurosis of the transversus abdominis and the internal oblique muscle at the level of quadratus lumborum. So it is between the QL and the aponeurosis is a QL1, the lateral QL. We see about QL2 and QL3 in the next slides. So now this is a ultrasound anatomy. Previous one was the cross-sectional view. So this is the QL1 here, where we inject a local anesthetic drug at the level of aponeurosis of transversus abdominis and internal oblique, a lateral QL, right? QL2 is a posterior QL, wherein we inject a drug between the ESP, erector spinae, and the quadratus lumborum, right? And QL3 is an anterior QL, wherein we lay the drug here, you can see here, QL3, between the psoas and the quadratus lumborum. This is our transverse process. So this is how QL blocks are divided into 3 parts depending on where the local anesthetic drug is injected. QL coverage. So basically, none of the 4 approaches has been shown to be superior to another. It is generally believed to cover T10 and to L3 dermatomal distribution. Lateral and posterior part can, lateral and posterior QL can cover T7 to T12. Subcostal anterior QL can cover T7 to L2. So basically, this is the QL coverage. However, we might not get a consistent blockade of T7 and T8. The QLs which we have given, we found that basically it could consistently cover T9, T10, T11, 12. T8 was plus minus, T7 was also plus minus. Based on the evidence, total publications are 258. Systematic reviews are 33, meta-analysis are 7, RCTs are 28. So a lot of evidence to a QL block. Based on this evidence, level 1B indication for abdominal surgeries. Hysterectomy, it has got a level 1A indication. Kidney surgeries and prostatectomy, it has got a level 1B. And lap gynecological surgeries is also level 1B along with lap cholecystectomy. Newer block, external oblique intercostal block. So if we remember the anatomy little more about the external oblique. So external oblique muscle is it originates in from the lower 6 ribs from T6, T7, T8, 9, 10 like this, and the direction is downwards and medially, right? It forms a aponeurosis at the anterior medial portion, right? So now external oblique intercostal block is a block where we keep a transducer at the level of mid-clavicular line and at the level of T6, T7 rib or even lower down. And we place a local anesthetic drug below the external oblique muscle and above the 6th rib or a 7th rib. So this is how the injection looks like, right? So the local anesthetic drug is below the external oblique muscle. And the coverage is kind of like this from T6 to T10, the medial aspect as well as the lateral aspect of the abdomen. So there's not too much of evidence. There are few case reports and case studies on liver surgeries. The cadaveric studies are there. Blocks anterior and lateral cutaneous branch of T6 to T9, T10 as per cadaveric dye studies. Subcostal tap was thought to be a variant of the rectus sheath block, and then it was thought that the analgesia is best at the anteromedial part than that of the lateral part. With the external oblique intercostal block, we are hoping that even the lateral part gets involved more than that, and also the anteromedial part, involving the anteromedial part as well. So external oblique intercostal can cover the lateral aspect as well. The other advantage what I felt is the catheters can be inserted pre-incision. It doesn't come in the way of the surgery. So we can put prior to incision and the can give a block and can tunnel it. So it doesn't come in their way. Now, when we pick up any analgesic option, we think about few things. We think that it should provide analgesia, it should be simple, it should be safe, it should be effective. Fascial plane blocks cover all these points. It should be reliable, it should be consistent, is something which we have to work upon. Fascial plane block can be prolonged by putting a catheter in, and it has also got a short learning curve. Now, what are the overall advantages of the fascial plane blocks? So there is an increased distance between the needle and the neurovascular structure, less potential for motor or hemodynamically significant autonomic blockade, avoidance of serious neuraxial complications secondary to hematoma or infections. These are less, but these are disastrous. And we don't know how much are reported also because they are disastrous. The other advantage of the fascial plane block are it is simple, it is safe, and it is effective. Take home message. Regional anesthesia is a part of multimodal analgesia, which is a pillar of ERAS. Regional techniques improve the quality of analgesia. Presently, the fascial plane blocks are used as a rescue where epidurals are contraindicated or failed. I would say fascial plane blocks should be in the toolkit of every anesthetist. Though there are few controversies, there are some problems of predictability. They are still inculcated in the guidelines, in the protocols, and in the clinical applications. So it should be one of the component in our toolbox. Arthur Clarke had said, like all revolutionary new ideas, the subject has had to pass through 3 stages, which may be summed up by these reactions. It's crazy. Don't waste my time. I think we have passed this stage. It's possible, but it's not worth doing. We don't know. I think we are in the second stage. I always said it was a good idea. A few more evidence and few more literature will tell us if we can go through the third stage. Thank you. Thank you very much. Any questions?
Yeah, it was wonderful, Sheetal. So the way you started it by explaining about the anatomy of fascia, that itself was so self-explanatory, telling about the mechanism of action. So it was very wonderful. So there are two questions from the audience, and one is that question is regarding the quadratus lumborum block, and the participant wanted to know whether the quadratus lumborum block also blocks the sympathetic.
Yes. So so basically the blocks, the quadratus lumborum 3, that is the one where we give a local anesthetic drug between the ESP and the quadratus lumborum muscle. It is thought that this block gives a visceral analgesia because in the cadaveric study it is found that the local anesthetic drug spreads towards the paravertebral space. Now, by and large, if you think logically also, the local anesthetic drug, when it is spread, when it is laid closer to the vertebra, they have to travel a less distance. So the chances that this drugs gives a visceral analgesia is high. So even for that matter, even posterior tab block, right? It is said that it might give a visceral analgesia, and even the QL block might give a visceral analgesia. Even ESP is said to give a visceral analgesia because these are all closer to the vertebra. The only thing what we can say is all these blocks gives a long duration post-operative analgesia. Whether it gives a visceral analgesia or not, it is difficult to find it out. But the opioid requirements are certainly very, very low, saying that probably it gives a visceral analgesia. Raghu sir?
Yeah, true. So the simple concept and the analogy is that if you are closer to the transverse process and to the spinous process, whatever drug or the local volume of local anesthetic you deposit, it easily traverses through the space. There is a costotransverse space from which the local anesthetic spreads into your paravertebral space. So that is one of the mechanism of ESP also, and other as well as the other plane blocks which are given closer to the transverse process. So that is how they block the sympathetics. Now coming to the second question, there is one more question. There are questions regarding the quadratus lumborum only. So at what level you can give the quadratus lumborum, and what is the volume you usually advise? Okay.
So basically, the quadratus lumborum is given between the subcostal margin or a costal margin, lower subcostal margin, and the iliac crest. As closer to the incision as possible, wherever you can see the quadratus lumborum muscle, the transverse process, and the aponeurosis. That part you can lay the local anesthetic drug. The volume of the drug that we can give is from 20 to 30 ml. Any fascial plane block is a volume block. So basically, any fascial plane block, we have to give a larger volume. And for the quadratus lumborum, we generally give 20 ml. If the body weight permits, we can give even a 30 ml volume in the quadratus lumborum block.
Yeah.
Is there anything that is left in this question to be answered, sir? I think that was the question, right?
Yeah. So ideally, if you ask me, quadratus lumborum is given at L4. That's a classic technique, and that's a classic landmark, ultrasound guided. Because what happens, your subcostal margin and your iliac crest only allow a window to see L4 to the best of the stone anatomy compared to L3. So that's why it's L4 is the ideal level where your quadratus lumborum is practiced, and volume, as she said, 20 ml to 25 ml you can give. So there is one more question about whether the QLB can be given in a supine position. So if you are giving in supine position, what are the comparable discomforts when you give this in 3 different QLBs in sitting position? Sorry, in supine position.
So I didn't get the question. Please, can
I
you
will
repeat it?
say that the
Can
QLB
you
position
break the
can be
question?
given in supine position. Whether QLB given in supine position. First question.
Whether QL can be given in the supine position. So yes,
Then
it can be given in supine position. Shall I answer, sir? What
yeah,
you answer? Yeah. Okay. So so QL1, that is the lateral QL, can be given in the supine position. Two things which we can do is we can tilt the patient, right? Because we have to go more posterior as possible, and we can keep a wedge under the abdomen, especially for the obese patients. Sometimes we need that wedge so that we can see it properly. For the thin patients, even a table tilt is something which is sufficient to give the QL1 block. But rest of the blocks, the QL2 and 3 blocks, it's better to do in a lateral position or a sitting position. So I mean, it is we cannot do those blocks in a supine position. The absolutely difficult to do those blocks in a supine position. QL1 can be done in supine.
I agree. I totally agree with you. So there's one more question: ESP versus QL block, which is better in abdominal surgeries?
Yes. So basically, the evidence what we have regarding ESP and QL for the abdominal surgeries is again same. Like both of them are equally effective for the abdominal surgeries. But again, I would suggest, based on whatever literature we have of the fascial plane blocks, it has shown that the point of injection where you give a local anesthetic drug, that point has got a maximum analgesia. That surface area has got a maximum analgesia. So keeping in point of the visceral pain as well. Now ESP, sorry, okay, ESP and QL both plus minus can give a visceral analgesia. That is one. Second is, how much is the contribution of the visceral pain? So basically, the contribution of visceral pain is not very high. It is only during the surgery and few hours post-op, where you can cover it with a small amount of opioids, like you see in laparoscopic surgeries. So basically, if I have to pick up the block for abdominal surgeries, I will pick up 12 than that of the ESP, unless and until there is a contraindication or there are some anatomical factors that will tell me to choose a ESP. But according to literature, both are same.
So I will put it in another way. I will put it in a very specific formulation. Okay. ES for thoracic, I use ESP, and for abdominal, quadritasone.
Yeah.
Nice, simple as that.
Yeah.
Now coming to the another question, what are the adjuvants you prefer?
Yes. So yeah, a very good question. Something which I wanted to actually add in my slide, and I somehow skipped it. So regarding adjuvants now, so if you remember, I had a slide about a fascial plane gliding, and the gliding is done by a hyaluronan. So this hyaluronan helps in the fascial plane gliding. When we inject an additive there, we don't know what will happen with this hyaluronan. That is one, that it's still a controversy. We don't know if there are any receptors there in those fascial plane block, wherein if we inject an additive, it will act on that receptors and give a good analgesia. That is second. Third is, we don't know if the same additive, if we give IV versus perineural, it gives a similar effect or not. So these are all 3 points. So something which we don't know, why should we do it? Now, additives are generally given for prolongation of the block. If we can put the catheters in, that's the best thing. The studies, there are a few studies where additives like dexmedetomidine and dexamethasone are given for the fascial plane blocks. I myself have practiced giving dexmedetomidine for the fascial plane block. It has worked very well, but at the same time, there was a small amount of hypotension for which I had to give fluids, wherein I had stopped using dexmedetomidine and I just use catheters.
Yeah. It's true. So I usually don't advise practicing any of the adjuvants, and Sheetal knows that. I always used to say, don't use any adjuvants. Because one thing you have to understand, facial plane blocks, they are the indirect blocks. You are not directly targeting the nose. So we really don't know what's happening and where it is going. So that's why we usually don't advocate. And even there is no much literature which supports the evidence of using the adjuvants for the facial plane blocks. I think we will take one more question. It's the last question. And the question is that which needle is best for the plane blocks and what should be the length of the needle in QL block?
For the QL blocks?
Yeah.
Which needle is best for the QL blocks?
Yeah. Yeah.
Okay, so so it depends on what you want to give. Like if you want to give a single shot block, then we can use a spinal needle. And if you want to use a catheter, we generally have a epidural needle with a catheter going in. I would advise to use a larger bore needle. So a 16 gauge epidural will be better than using a 18 gauge. And even for single shot, I would advise to use a larger bore spinal needle, because the needle is really well seen on the ultrasound if you use a larger gauge needle. For the epidural one, the catheters are a little flimsy with the 18 gauge epidural catheters. So there are chances that the catheters do get blocked. The chances that there is a kinking of those catheters, the chances that while putting the catheters, it doesn't go as easily as it should go. So it's better to use a 16 gauge epidural over 18 gauge. And for spinal needles, you can use a 22 gauge. And so 20 gauge is also sometimes fine if you are a beginner, but then you can slowly, steadily go to 22 as well.
Yeah. So true. But I differ about the gauge of the needle because the thinner the needle, the visuality is again better compared to the thicker. And we can argue on that, no problem. But that is what is my observation about that. And as she rightly said, so if you want to really put a catheter, so you have to take a wider bore needle, 16 gauge, 18 gauge really gets blocked and it becomes very difficult to infuse the medication later on. And I think we have almost reached the end of this session and we have quite answered almost all the questions.
I just wanted to ask a question. Sheetal, can you take this one? I wanted to ask about the erector spinae block. So if you have an incision in the 5th intercostal space and you have an ICD in the 8th intercostal space, which would be, and you're doing a single shot block, where would you inject?
So 5th and 8th is what I need to cover, right?
Right.
5th and 8th. So then I could just block in between, in the middle. So maybe at 6th or 7th. Here, the ESP block spread is very good at the craniocaudal direction. So even if here it's 5th and 8th, but even if it is 4 and 8, I just have to increase my volume.
So how much would you use?
So for this, even 20 ml should be sufficient, madam.
Okay. And the other thing I wanted to ask is, what is your general practice? Do you do these blocks while the patient is awake and in lateral position, or do you do them at the conclusion of the surgery with the patient asleep, or just after induction?
So basically, there are different practices, but the standard practices, the patient is intubated, not under mild sedation, but we do these blocks after intubation or LMA, whatever is mode of anesthesia that is decided. That is one. Second is whether we do it after the induction, that means pre-incision, or after the surgery. So basically, that was one of our study which we had forwarded. So basically, we have found that the pre-incision blocks, if we give those blocks, it is better in terms of opioid requirement. Intra-op opioid requirement does go down. We understand that our block is working just like an epidural one, right? So best way is to give it pre-incision. But standard practice in in majority of our consultants that they do is at the end of the block, basically because sometimes the incision gets prolonged. We decide with this incision and the incision might get little more, and then it might change the level. So these are some, so that's the reason
Supplemented with an intercostal.
at the end of. Sorry, madam.
Supplemented with the intercostal by the surgeon, right?
Intercostal is given by surgeons. Madam, your voice is echoing, so I could not hear the full words.
Okay. Okay, leave it.
Intercostal by surgeons. I hope if I've heard right.
Yeah, yeah.
Yeah. Okay.
And I was also going to ask you about the use of PCA along with this.
Yeah, true. So like for the abdominal surgeries, most of our patients don't need a PCA. Maximum patients, if the don't need a PCA, if we have given a catheter and the facial plane blocks. For thoracic surgeries, by and large, we empirically put them on the PCA and we just see the opioid requirement, because it's just a a kind of a starting phase, and the thoracic is surgery is believed to be very, very painful. But I feel that even those PCS, we after few years, we can just gauge and then give them.
So basically, it's your experience that counts. So in the initial period, supplemented.
Supplement,
Is the
yeah.
better now?
Sorry, madam. Yeah, it's better. It's better.
Raghu, if you want to conclude.
To conclude,
Yeah.
I can say that facial plane blocks are indirect blocks. So you are definitely not targeting. So you have to be very careful whenever you're choosing which type of block you want to give. So what I can say that yeah, I definitely say that we are moving away from the neuraxial blockade, but wherever possible, kindly put an epidural. And if epidural is contraindicated, yes, you really have to know this techniques of giving a facial plane blocks. Second thing is that because facial plane blocks, like they are not bilateral, so if there is a midline incision, you have to give on both sides, or if the incision is from your xiphisternum to pubic symphysis, then you have to give 4 levels, subcostals, then classic tab block. So logistically and technically, it is very tedious. That is there. And another thing is that when you are putting a catheter, the chances of catheter getting migrated out are much higher than the epidural, because there is no firm structure which may be supporting your catheters when you are doing these facial plane blocks. So that's why again it becomes very difficult. So that is again a technical challenge, I can say. Another important take point is I will say that the volume of the local anesthetic which you are injecting, you have to be very careful, because you are injecting a large volume of local anesthetic. So you have to be very much be aware that the chances of blast may be there in such group of patients. So with all these things, I can say that I conclude this session, and I hope Dr. Sheetal has made the points or very clear about the practice of the facial plane blocks with respect to the particular surgeries. So thank you very much. Thank you once again, and I hand it over to Anjali.
Thank you, Dr. Chota. Many thanks, Sheetal. That was an excellent elucidation, and it was very helpful to all the delegates. You had very good audience as well, and I would like to thank those of you who have stayed on until this late to listen to the discussion. And thanks to Raghu for all the practical tips that he's included at the end of the session. I hope that this will help us in incorporating facial plane blocks in our practice. And I think the sono anatomy has been well explained during this session. Thank you so much. I'd like to hand over to Mona Lisa now to conclude the session.
Thank you, madam. Thank you.
So I'd really like to thank Sheetal ma'am to deliver such a brilliant talk. Thank you so much once again, ma'am. So Clarinet is really glad for all these brilliant people together in this session today. And thank you so much for extending us the opportunity to host the session. I hope you had a seamless experience. With your due permission, I'm closing the session today and looking forward to hosting you again. Bye. Good night, all of you.
Good night. Thank you.
Thank you. Good night, madam.